Hello, everyone. Welcome to today's live broadcast, the role of LC-MS-MS spectrometry in diagnosis of various endocrine disorders. I'm Brenda Kelly-Kim of LabRoots, and I'll be your moderator for today's event. LabRoots is the leading scientific social networking site, and we are proud to bring you this interactive web seminar. For more information, please visit us at www.labroots.com. Here's how this presentation works. We want to hear from you. Questions, comments, and even answers can be submitted through the green Q&A button at the lower left of your screen. We'll try to get to everyone, but if not, we'll make sure to follow up with you via email. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear this presentation properly or see it, let us know by clicking on the support button at the top right or the Q&A button in the lower left. This presentation has been approved for continuing educational credits. Please click on the CE button at the bottom left corner and follow the process to receive your credits. I would now like to introduce today's speaker, Ravinder Singh. Dr. Singh is the director of the Mayo Clinic Endocrine Laboratory. He has focused an area of investigation that has broad applicability to the field. Dr. Singh studies the application of liquid chromatography tandem mass spectrometry, LC-MS-MS, to clinical laboratory analysis. Many of the methods that Dr. Singh developed are now considered reference methods. They have subsequently been utilized for standardization efforts, as well as to establish clinical disease correlates, which he has published with his collaborators. Dr. Singh's work has directly contributed to improving methods for the clinical diagnosis of Cushing's disease, pheochrmocytoma, and congenital adrenal hyperplasia. Continues to work to discover innovative ways to better understand the use of LC-MS-MS in providing patients with faster and more accurate diagnoses. I would now like to turn the presentation over to Dr. Singh.
Thank you, Brenda. We'd like to thank LabRoots also for hosting this talk, and definitely appreciate attendees coming online and joining me today as live, and if you will be joining us later, that would be great as well. So the topic which I'm going to talk today is role of LC-MS-MS spectrometry in diagnosis of various endocrine disorders, and I have the privilege of working at Mayo Clinic for the last 15 years and have been experiencing the role of this technology in a clinical environment. So the objectives I have today would be that I would like to discuss some strengths of tandem mass spectrometry in clinical lab to have a better patient care. But every technology comes with its cost and other technical challenges, and hope some of my examples will also highlight them. Outline of the talk would be that I would like to discuss some issues related to the cortisol testing for the diagnosis and screening of Cushing's disease or syndrome. I would like to also spend a little bit time on congenital adrenal hyperplasia, and I'm sure in the end I would like to finish with a little bit more discussion on sex steroids and vitamin D. So here is a patient who looks like he has a Cushing's disease, and that's what clinicians are educated and taught in the medical school. The patient has moon faces and has a hypertension and is obese. And if you look at the back, he may have some fatty pads as well. But recognizing a patient who has a real tumor versus in general, because obesity is very common in the US, is a challenge which our clinician colleagues have to work with. Cortisol is secreted from the adrenal gland, and this particular cartoon just shows that adrenal glands are located at the top of the kidneys, and the generation of the cortisol is regulated by a pituitary hormone, which is called ACTH, and ACTH will act on the adrenal gland will make cortisol, and if the cortisol is more than what the physiology requirements are, then it will send a negative message to the heart receptor, and the ACTH secretion will go down. So secretion of cortisol in a normal individual is very well regulated mechanism. But unfortunately, if somebody has a pituitary tumor, that means it's an unregulated secretion of ACTH, or somebody has a tumor at the adrenal gland, that means the cortisol is also secreted in unregulated manner, and those are called Cushing's disease or Cushing syndrome. This is the cross-section of the adrenal gland. The top yellow part is called cortex, inner brown dusky color is called medulla. The inner medulla is responsible for the secretion of catecholamines, which are dopamine, epinephrine, and norepinephrine. And adrenaline is also the name which is commonly used in Europe, but the cortex is responsible for the secretion of steroids. When physicians are doing the workup to confirm whether the patient has a pituitary tumor or the adrenal tumor, they would like to order, in addition to the ACTH, a number of cortisol tests. And some of those tests are listed here. It could be urine-free cortisol, which has been considered to be gold standard for a long time. And then patients can also be told to collect plasma cortisol. And the new tests which have entered the clinical field is plasma-free cortisol, midnight plasma cortisol, and midnight salivary cortisol. Like I mentioned before, the symptoms you saw in the patients with the Cushing disease are pretty common of the symptoms what we see in the general population as the obesity is increasing. So some of these diseases and syndromes are also associated with the hypercortisolism, and it is a challenge for the physician to find that one rare patient who can be cured with the surgery by removing the tumor from the pituitary or from the adrenal glands. The steroids are complex analytes in circulations. Most of the time when a physician orders steroid or cortisol, we give the physician back a total cortisol in blood, which is the sum of the free cortisol bind to the binding protein, for example, cortisol binding globulin, or cortisol bind to the albumin. But there is a form of the hormone which is being used. In some cases, it's called bioavailable, which is the sum of the free plus albumin. And of course, free is a steroid itself. But most of the steroids in human circulation have a very short half-life. They're very bioactive and potent hormones, so body has to clear them. But for clearing in the urine, they need to be conjugated to the gluconide and sulfates, which increases their polarity and helps in getting excreted in the urine. The steroid testing in the clinical lab or in research is something which we have been knowing for a long time. And very first time, Dr. Zimmerman had this assay in 1935, where it was a colorimetric reaction where we could look at the metabolites of cortisol and the androgen, and it used to be called as 17-ketosteroids. In 1952, the paper chromatography was brought into use, and it helped in separating various steroids one from the other. And then later, that switched to the column chromatography and detection by some kind of colorimetric. In mid-80s, the chromatography was joined with the flame ionization detector, where one was able to use meters-long column and gas chromatography, but then using flame ionization detector where you were able to burn the steroid as a carbon source and then get the signal. The radioimmunoassays were discovered in 1980s, and the Nobel Prize was given to Dr. Rosenyellow for making these assays available. And in this case, one could use the antibodies against very small concentrations of steroids, which, for example, could be the unconjugated steroids for plasma steroids. And before that, all these assays were used for the urine metabolites only. But very quickly it was realized that at low concentrations, there are interferences which are possible in the serum antibody assays. Then, to confirmation, we had to use GC mass spec assay, but the GC mass spec was very laborious and it was not very practical for most of the clinical lab, and they did rely upon the immunoassays only in extreme situations. GCMS was practical and usable. As a clinical lab, we have a number of technologies at our disposal. For example, radioimmunoassay, If we have to develop an assay which is not commercially available, we can get an antibody and use radioactivity, which is of course not very attractive to the people who work in the lab. Then radioactivity can be replaced by the chemiluminescence, or we can use enzyme-like immunoassays or fluorescence or chemiluminescence assays. But if you would like to remove the interferences from the plasma and use chromatography technique, then again we have many choices. For example, GCFID, LCUV or electrochemical, GCMS, LCMS, or LCMS-MS, or also called tandem MS. Ideally, clinical lab would like the lab to be clean and everything highly automated, and having all these analyzers communicating with the automation line and all these results being reported to the physician's computers as quickly as possible. And we are proud that some testing is reported back to the physicians in 30 to 60 minutes, and by the time patient goes back to the appointment, the results are available. But the topic today is that LCMS-MS has filled the gap either because of the limitations of some of the immunoassays or some problems with the immunoassays. So here is an example here that we will have three kinds of assays in the immunoassay categories, and this particular cartoon will highlight that. You can detect a analyte, which is like a protein here, by using the sandwich assay, where you can have a capture antibody which will bind to the antigen. Then you can wash the matrix and other interferences. Then you bring the second antibody which has a label on it, and then you can detect the concentration of the analytes. The other possibility is that the analyte could be very small molecular weight like cortisol, but in that case you cannot use a second antibody. You have to rely only on single antibody, but in that case you have to use a labeled, a tracer, which is a comparative immunoassay. So some of the limitations of the comparative immunoassays are that the antibody can have a cross-reactivity with the steroid or steroid conjugate, and in addition, this particular section on the right shows that the dynamic range of the assay is very limited. If you notice at a lower concentration, the change in the signal is very small, and the same is true at the high end. So we have a very small dynamic range where the assay is useful for clinical purposes. Most of the manufacturers who make the immunoassays will check the cross-reactivity with the antibody used in the assays against the various interferences, which could be steroid metabolites or steroid precursors. Here is a great example that one of the vendors tested the cross-reactivity of the cortisol antibody against allotetrahydrocortisol, corticosterone, cortisone, and 11-deoxycortisol, 21-deoxycortisol. And here is a drug which is commonly used, prednisolone and prednisone, and seems like this particular antibody had a very high cross-reactivity with this particular steroid. So if these patients are on these drugs, which are popularly used for rheumatoid arthritis or for joint pains, then in that case, the cortisol result will not be reliable from the immunoassays. And physicians have known this for a long time, and they have been asking. Here is an example of a citation in 1999. And Dr. Murphy has said why the labs still keep on continuing using the immunoassays when we know we have these problems by using antibodies. So at one time in our lab, we had these three methods live because in 2000 or so, we were using the urine cortisol assay by using one of the automated assays even after extraction. But if you notice here, the reference range for cortisol was 108, the high end. But because there were some interferences, physician will call the lab, then we used to run those samples on HPLC-UV. But then HPLC-UV was not perfect either. Then we used to run once a month LCMS technology, which was like the old style mass specs. The point on this slide is that if you notice here is that by immunoassay, the reference range was up to 108, but by the HPLC assay, the cortisol was 55. So that means the antibody did have a cross-reactivity with some other metabolites, especially maybe it was with the cortisone. Here is an example here where the sample was analyzed because the results were not acceptable to the clinician for immunoassay. But if you notice here, even after spending a lot of labor to extract the sample, you spend 30 minutes on the HPLC, the UV detector was not very specific. This particular steroid still interfered in the middle here with the cortisol and cortisone, and this was not the best case scenario. So this particular sample was run further by the mass spec, and where it was a much better signal to noise for the cortisol and cortisone, and we did not see the effect of the other steroids. But now, instead of using LCMS, most of the big reference labs and good-sized clinical labs are using LCMS-MS, where you don't need 20 minutes retention time. Rather, you can get results within a few minutes for both cortisol and cortisone. And you can also use internal standard to account for any losses during the extraction or any suppression on the mass spec or any suppression in the needle or the HPLC system. So question is it worth going to the tandem mass spec versus the immunoassays? And this particular slide will show the answer should be yes, that because the immunoassay results are not comparable with the gold standard method, which is the LC tandem MS method. The problem was not only that the slope was only 0.35, but in addition, the correlation was only 0.5. A good method comparison should have slope of 1 and R-square of greater than 0.9 or higher. So that means immunoassays are recovering more than just the cortisol, but also it's unpredictable for certain samples. So in 2000 or so, or 1998, we had many comparative immunoassays. This particular slide was put together by one of my esteemed colleagues here. And we used to have no mass spec in 1998. We had a lot of HPLCs, but by 2009, we were able to convert all the immunoassays for small molecular weight steroids or other drugs and amino acids to the MSMS, and at that time we had 58 triple quads in our lab environment. And we were able to convert some assays from HPLC and GCMS also to the tandem MS. So currently we have a significant volume of the mass spec assays in multiple labs. We have also one assay in the anatomic pathology lab. Biochemical genetic code and newborn screening is doing a number of assays. Cardiovascular lab is using it. Endocrine lab is using 28 different tests to be done by the mass spec, and toxicology is also using a number of methods for drugs and toxic substances. So this is what it looks like in big reference lab. It's almost like a very high dense population of the mass specs, and some labs have gone to increase the throughput, have a very complicated HPLC in front of the mass spec. So in order to set up this environment, you do need an investment, which is expensive, but you also need very highly qualified and trained people to go from an automated analyzer to the manual mass spec assays. Because all these assays will be considered as lab-developed tests, and they are not approved by the LC mass spec vendors for clinical use, that means every lab has a responsibility to make sure they do a very rigorous validation, and that would include precision, which would be intra and inter-precision, accuracy, which would be method comparison, and recovery. We need to make sure that we have a good reportable range and reference range. Of course, we need to determine LOD and LOQ, and make sure the mass spec method is also specific. It is relatively more specific than the immunoassays, but again, we have to make sure that all the possible drugs and metabolites and not interfering in the mass spec assays. So this particular slide shows that if you could provide a good test to the clinician, and then that helps in the patient care. So patient on my left had a tumor which was taken out, and after the surgery, this patient became normal. Otherwise, this patient may have died within 5 years if this patient's diagnosis was missed because of the inaccurate cortisol assay. So the cortisol testing is very critical, and one should look at the advantages and disadvantages of various technologies. Sometimes Cushing's can also happen because of the exogenous steroid use. And here was a young girl who came to Mayo Clinic who was using steroid maybe 1 year back for some knee pain and had all the symptoms of Cushing-wide, and she had gained weight. And the physicians and the clinicians did all the imaging and all the blood work, urine work, and we could not confirm that this particular girl had a tumor. In that case, the physician went through the history and asked the lab, should we check whether this patient still has the steroid which she was using. This is just an example that we do see a lot of steroids coming out in the market, but unfortunately, a lot of safety data is not available. And some of those steroids have very similar structure and chemical formula to cortisol, and that's the reason they may cross-react with the antibodies. So we would have to develop LC-MS assays for various steroids to confirm if the patients are taking any of these steroids. When we developed this assay and tested this patient sample, we were fortunate to see that we were able to see small amount of triamcinolone acetonide, which is also known as Canalog, which this patient was taking almost a year back, but somehow this was deposited or stored in this patient and was being released at small amounts. So that was the reason this patient was having symptoms which got resolved after 1 year of discontinuation of the steroid. And that solved the mystery for the clinician. So I would like to talk about that LC-MS can develop multiplex assays for multiple steroids, not only for drugs or exogenous steroids, where the sensitivity may not be as a challenge versus when you're looking for endogenous steroids. They exist in very small concentrations, and the steroid pathway is very complex and complicated. And if you notice here, as the enzymes are involved, for example, 21-hydroxylase enzyme will convert 17-hydroxy progesterone to 21-deoxycortisol, which will then convert to cortisol. And there is a disease if there is an absence of the 21-hydroxylase that's called congenital adrenal hyperplasia, and the patients can have symptoms when they are newborn, and I will show you the picture of that. So here are two sisters. The first sister was born with a disease called congenital adrenal hyperplasia because she didn't have the enzyme of the 21-hydroxylase. And if you notice here in this slide, the 21-hydroxylase was converting 17-hydroxyprogesterone into 11-deoxycortisol, which this patient could not convert. Rather, 17-progesterone will be very high in this particular child, which becomes source of the testosterone. And that results into ambiguous genitalia when the fetus is exposed to the excess androgens. When the sister of this baby, when the mother was pregnant again, was treated with by the clinicians, then the outcome of the second sister was fine because she was under the care of the clinician. This particular slide shows that LC-MS has a capability of developing mass spec method within 9 or 10 minutes for 10 or more steroids. This is what we tried in 2000, but number of other labs and manufacturers of LC-MS have shown again that you can develop multiple assays and any steroid combinations you want, any combinations you want. For example, in this case, the 25-hydroxyvitamin D is also listed, and estradiol is also listed. You just have to look at your need, what kind of method you need to develop. But LC-MS has a capability you may have to invest into that. You need longer chromatography to resolve some of the interferences because they may be the isomers of some steroids. This is another example here. If you need limited amount of steroids, then you can shortcut the method down to 4 minutes and you can still have almost 4 or 5 steroids, which could be very relevant in the workup of some patients. The sex steroids also have been known to have problems with the antibody assays. And here is an example from the data from College of American Pathologists. In case that endocrine, the sample which is sent to multiple labs, there was a lab which reported 17 nanomoles or 17 nanograms per DL, but there was a lab which also reported 23. But look at the estradiol. Estradiol was reported as low as 25.7 by one lab, but there was one lab which reported 227 for the same sample. So we are dealing with these situations, and physicians are not very happy when the patients go from one lab to the other lab, that our methods are not standardized among the labs and among the various manufacturers of the immunoassays. But if you compare two LC-MS assays, here an example of the testosterone testing being done by CDC and also done by Mayo here. And then if you compare, and this is the perfect case scenario where your slope is almost 1 and your R-square is 1. So before you change one method to the other method, and if your previous method was working very well, this is the kind of comparison you're expecting for the method comparison. So the endocrinologists have understood this problem, that labs have these limitations, and they have put very strong wording into their guidelines. For example, this is the Endocrine Society position statement, which says that we not only need precision and we also accuracy. According to them, lab PT testing should be based on the ability to measure accurately, which is going to be very hard for clinical labs to deliver because different vendors' methods are different and we don't compare very well with each other. But of course, clinicians now are educated and they're looking for that our method should only be not only precise and reproducible, but they should also be accurate. Here's an example of estradiol, which is a little bit challenging because the levels of estradiol and estrone are much lower than compared to the testosterone. So if you try to make a mass spec method or tandem mass spec method for underivatized estrone or estradiol, it doesn't work very well. So then you need a help to derivatize with a chemical which is called densyl chloride or other derivatizing agent, which enhances the ionizing properties of the complex here, which gives you much better intensity. But the drawback would be is when you do the tandem MS on this, 5 or 6 breaks into 171, which is part of the derivatizing agent. Since you are derivatizing a lot of molecules which are similar to estrone, estradiol, may have 171, so you have to rely upon only the Q1 signal, and that's where the tandem MS is helpful compared to just GCMS or LCMS. So, of course, you require a good chromatography to separate E1 and E2. You can use deuterium labeled E2 and E1, and now this is our old method, but you can also buy C13 labeled estradiol and estrone 1, which are always preferred because otherwise deuterium have the deuterium exchange. So I'm going to move into an example of vitamin D, which is very popular in the clinical lab these days. And vitamin D is normally made when you expose yourself to the sunlight, but in America, in North America, we don't have a very good sun coming to the, especially in winters, so we don't make as much vitamin D as people living on the equator. So people with the dark skin also have disadvantage that they can't make synthesis of 25 hydroxy vitamin D. And then the 25 hydroxy vitamin D can also be low because vitamin D needs to be converted into 25 if somebody has a liver diseases or some people are unable to absorb vitamin D. And some medications can also interfere in the absorption and the conversion of vitamin D into 25-hydroxyvitamin D. But the recent literature has shown interest that vitamin D deficiency could be associated with multiple diseases like in psychiatry and cardiovascular diseases and cancer, in addition to what we have known for a long time in osteoporosis or osteomyelitis, osteoarthritis, or rickets. This is just an example of what we saw in our lab. There was a rapid increase in interest of vitamin D, and our volumes unexpectedly went very high. And we had to make a lot of adjustments in our LC-MS method to capture this volume. This pink here is listed a assay which should not be ordered as commonly as 25, but sometimes because both assays have vitamin D in the end, the second assay gets misordered. So in 1981 at Mayo, we used to do HPLC assay that had a very low throughput. Then we converted to the radioimmunoassay because that allowed us to have a bigger batches. But then as the need went up, in 2004, we evaluated automated analyzer and compared that with LC-MS, and we end up making a decision that we should go with the LC-MS and not go with the automated analyzers. Of course, like this is just a reminder here, automated analyzer is always attractive and has a lot of advantages, and they should not be underestimated because a lot of manual errors can be prevented. When you're dealing with a complex steroid or complex hormone, then you have to worry about what are the possible interferences if you're using an antibody assay. In this case, vitamin D gets converted to 25-hydroxyvitamin D by the liver, and then based upon the need and the calcium need, a small amount of 25-hydroxyvitamin D will be converted to 125-dihydroxyvitamin D. And here is a small list of various vitamin D related metabolites for which you would have to make sure whether your antibody-based assays or LC-based assays have shown that they have no cross-reactivity or the levels are low enough that there is no clinical impact on the patient care. This was an example here where it was shown that a very popular assay which was being used by 163 labs gave a mean of 24 nanograms per ml with a very good, relatively okay CV of 15%, but when the 24 labs were using a radioactivity-based assay from the same company, which has the same antibody, but one was automated, one was extracted radioimmunoassay, there was a difference in the mean value between the two group of labs for the same sample. And the labs, there were 44 labs which were using the LC-MS or LC-MS assays. They were finding the value to be 12, which was closer to the radioimmunoassay, which was extraction-based, but somehow the automated assay had much higher value. So people who cannot afford LC-MS assays have developed HPLC UV or HPLC electrochemical assays. The only caution in those situations is that you would have to make sure that your chromatography has been long enough that you're away from the wall volume and most of the metabolites are separated from each other. And this is a great example published in 2000 Chem that you're able to separate not only from D2 and D3, but you can also separate 25-hydroxy-epi D3 from 25-D3. Here is an example of the LC-MS assays. When your volumes are high, you can use multiplying HPLCs, and you can get results within 1 minute, which is giving you a separate value for D3 and D2. And of course, you are using to calculate the unknowns as a ratio with the internal standards, which are available for both D2 and D3. These are some of the slides which will highlight that LC-MS procedure is manual. So you have to be on the bench. You need a trained workforce, they have to create their batch, and you can use somewhat semi-automation here. Here is an example here. We are using the pipetter to help the technologist here to pipette the sample into the crash plate. And then the crash plate gets spun down and then get vortexed. And then you're kind of filtering it here so that you are able to get the supernatant, or in this case, the filtrate into the bottom plate, which can inject it. And in the top, you will have some kind of protein precipitation left. And then you have to make sure that all the process went, that you can see the sample. This is a very hard, you need a very good eyes, and it's a very manual process. And then you trust that all the process went well, then you put on the LC. And in this case, you put the tray at the right place, and then multiplexing 2 arms. In our case, we're injecting samples back to back. And this is a complex HPLC, which is using multiple LC systems. 4 LC systems, and here's a WIM module which is helping in getting the samples done on a timely basis so that we can report within 24 hours these results back to the patient and back to the physician. And this is just a zoom up that this is a challenging because leaks do happen in the lab and the columns do go bad. Columns are expensive. The maintenance of this valve is expensive. But if you have chosen this route, then it is something, the expertise you have to build. And it could be cost effective if your volumes are high. Just some of the slides highlighting, of course, compared to the automated immunoassays, you have to review the chromatography and maintain the pressure of the columns. So it is almost like you have to babysit sometimes. And this is another drawback here, that after you all do all this work, then you end up collecting a lot of waste which needs to be disposed of according to the safety and regulatory environment and then those regulations. This is the dream we all have that can be taken advantage of, the automated machine, where we don't have to do manual pipetting, but instead of using chemiluminescence or fluorescence detector, if there is a manufacturer out there who can put a mass spec detector into the machine and then give us the best of the 2 worlds. This is an example here that if you are using either HPLC assay or tandem mass spec assay, that both assays are very well comparable to each other. Again, the slope and the R scales are very good for both D2 and D3. And then you can use either one of those 2 assays. So the throughput for HPLC will be, of course, lower than the LC-MS assay. There was a study recently done which did compare different technologies for the estimation of vitamin D. And this particular paper was published in PLOS ONE in 2010. And their conclusion was that the most valid method is HPLC mass spec method compared to the automated assay or the manual ready immunoassay. And some of the data is shown in this slide here. So they just tested a number of patients by 3 different technologies here. So these are same samples have been tested by 3 different methodologies. And the point they're making is that if you test the number of samples by using the blue line, which is the automated immunoassay, your conclusion will be that there is a 40, 42, or 45% of your population which is below 50 nanomoles per liter of 25-hydroxyvitamin D. If you test the same number of samples by using extracted ready immunoassay, then the conclusion will be is it's only 20% of the population which is below 50 nanomoles per liter. But if you use HPLC assay, then you will say that it's only the 10% of the population which is below 50 nanomoles or 20 nanograms per ml. As you can see here, there is a huge implication on the patient care here, because if you believe that HPLC method is correct, then only 10% patient will require vitamin D supplementation. Otherwise, 42% may be given vitamin D unnecessarily. So I would like to conclude here that both LCMS methods and immunoassay methods are very commonly used, and one has the responsibility, if you are the lab director, lab supervisor, or the lab technologist, that you have enough data to support the method you are using to get the results. So it does have a big impact on the patient care. And then since the LC-MS methodology is becoming popular, a lot of applications have been published, and a lot of help is available, I would encourage the listeners that you should consider it and look at its pluses and minuses before you decide to bring a new assay in your clinical lab for patient care. I would like to thank for your attendance. Thank you very much.
Thank you, Dr. Singh, for that informative presentation and for spending time with us here today. I just want to remind our audience how they can submit their questions. Questions can be submitted via the green Q&A button, the lower left of the screen. We'd like to hear from you. While we're waiting for our audience to get their questions in, I'd just like to pass it back over to Dr. Singh for any concluding or final thoughts he has about today's presentation and this field.
Thank you again, Brenda, and all the attendees. Really appreciate your time. And email is here. We'll be happy to interact with anybody. Again, my experience at Mayo has been that we have implemented this technology, but again, we have learned a lot, and we have to learn still going forward. Now we are trying to use this technology for complex molecules, which are proteins and peptides and antibodies. But definitely the goal here is that all these tools are available, and we just need to make a good selection of the method for better patient care. Thank you, Brenda.
Thank you again. Your contact information is right up there on the screen, so perhaps some of our audience members will get in touch with you directly. We'd like to thank you again, Dr. Singh, for being part of today's presentation. We would want to let our audience know that we will be having this broadcast available on demand through May of 2016. You'll be receiving an email for that, and we hope you will share it with your colleagues. Before we go, we do have a question from our audience. Bing from Bing Laboratories asks, for 25 hydroxyvitamin D LC-MS test, what kind of QCs are you using, and what are the batch receptance criteria?
Thank you. That's a great question, and I appreciate the question here. We used to buy the quality control material from a commercial vendor, and the typical practice in my lab is that you will run 20 inter-assay precision batches to determine the value, so you don't get the value from the vendor who makes these controls. So you have to determine your own value before you start using this QC. So you determine for 20 days different batches, and then take a mean and standard deviation. The QC CV is not going to be any different or better what the QC you determined when you were developing your assay. Ideally, the QC or the CV of the assay should be less than 5%, but unfortunately we are not there yet, so I would not go higher than 10% for any QC for any clinical lab. But I know there are exceptions, and we have to work with them, and then hopefully we will improve our technologies and get better assays. Now, because the quality control material is expensive when you buy from outside, you can always make your in-house quality control by spiking into either waste serum or plasma, or you can buy from strip serum, which have very low levels of endogenous D2 and D3, and you can make your own controls as well, which is totally acceptable to CAP. Thank you.
Thank you, Dr. Singh. Thank you to our audience for such a good question. Remember, the presentation will be available on demand. When you hear from us from LabRoots, please pass that notification on to any colleagues who might have missed today's live event. Thank you again for being with us, labroots.com, the leading scientific social networking site. Hope to see you again.